Hello, I'd like to talk to you today about the treatment of latent tuberculosis in persons living with HIV. So let's go ahead and begin. I want to briefly touch upon the epidemiology and the progress of treatment of latent tuberculosis, discuss what reasons there are to treat when you're already on antiretroviral therapy, um, what are the different regimens and options for treatment, what considerations we need to take into account given the antiretroviral selection and known drug-drug interactions, and also briefly describe some special situations such as drug resistance exposure, pregnancy, and the role of repeat courses. So let's begin with what is the TB burden and the goal of TB elimination. So the WHO has shown that between 2000 and 2019, TB incidence has been slowly declining, and that is both with people living with HIV, as is shown in the red lines, as well as those who do not have HIV. However, the decline has been slower than desired. And currently, tuberculosis is the #1 infectious disease morbidity mortality among persons living with HIV, with the greatest burden happening in low and middle income settings. There are a total of 10 million cases, of which 10% are estimated to occur in persons living with HIV, making this a very important problem. And specifically for Thailand, when we look at the epidemiology, in 2019, 105,000 people were diagnosed with TB, of which 10,000 are estimated to have been TB HIV co-infected, and there were 11,000 deaths. And importantly, of those 10,000 individuals who fell ill with TB, we also have to think about preventing people with HIV from becoming diagnosed with TB. And so we have some room for improvement in places like Thailand. Here in the lower left hand shows the TB preventive therapy, and it's estimated that 0.41% of HIV positive people are on TB preventive therapy. And 56% of children under the age of 5 are on TB preventive therapy who are contacts of a known TB case. And so this, I think, will really benefit from improved scale-up of TPT, as it's known, which stands for TB preventive therapy, and I'll use that routinely. I think the other challenging factor, of course, the world is a very changed place. 2020 brought the impact of COVID, and fortunately, COVID has had a dramatic effect, particularly in some countries more than others, on TB notification. Here you can see several countries, high burden countries, with Thailand on the bottom panel showing some decline in reporting, particularly over the summer months, and other places like India where there was a dramatic decline because of a national lockdown. Now, there are clear goals that have been set as part of this ambitious NTB strategy that the Global TB Program through the World Health Organization and partners has undertaken. And they're listed here, and they include a dramatic reduction of 95% in number of TB deaths by 2035, a 90% reduction in TB incidence, and 0% of families facing catastrophic costs due to TB. In order to do that, it is clear that finding and treating active TB alone is not enough. And these are data from some time ago showing the different strategies that can be used to address the TB epidemic. We can address risk factors, things like smoking cessation, diabetes, treating HIV with ART. In the orange bar, you can prevent infection. And then, of course, you can treat latent TB, which has an important impact. You can see that light blue line. And then treating both active and latent TB, the combination is really the best strategy in the absence of effective vaccines. So really, we need to do both. And the way that we can also address preventive interventions for tuberculosis is to prevent infection. So doing good infection control, particularly in healthcare settings, and doing case finding strategies, reducing susceptibility by taking care of smoking cessation and diabetes. And a lot of these comorbidities exist in our HIV co-infected individuals. And of course, much of this lecture is going to focus on the role of TB preventive therapy. So what's the current guidance for latent TB treatment in persons living with HIV in low and middle income settings? So for this, I turned to the WHO guidelines, and you can see these are available on the web. But the statement that they make for adults and adolescents living with HIV, first, obviously, they should not have evidence of active TB, but all persons living with HIV should receive TB preventive therapy as part of a comprehensive package of HIV care. And treatment should be given to those on antiretroviral therapy. They also recommend to pregnant women, as well as those who've previously been treated for tuberculosis, irrespective of their degree of immunosuppression, and even if the LTBI or latent TB infection testing is unavailable. This is a strong recommendation and has high certainty in the estimates of effect. With respect to children, the recommendation is that infants less than 12 months who have HIV, who are in contact with a person with TB, and who do not have evidence of active TB should receive TB preventive therapy. And children who are 12 months or older with HIV should also be offered TB preventive therapy as part of a comprehensive package of HIV prevention and care, particularly if they live in a high TB incidence setting. And that's regardless of whether they have known contact or not. So there's a differentiation between very young, less than 12-month infants and those who are children 12 months and older. So what's the role of latent TB testing in persons with HIV? Well, it is recommended to perform testing in low incidence settings as a matter of standard of care. So tests like the tuberculin skin test, the IGRAs, are what are routinely done. However, in high incidence settings, and also because of the challenge of getting access and the cost and the need for return visits with things like the tuberculin skin test or a specialized lab setting, as in the case with interferon gamma release assays, the recommendations generally do not absolutely require it. However, they do help to identify persons who are at high risk of progression. But I will say that in HIV-infected persons, the sensitivity and predictive value is truly suboptimal. And so these tests, while they provide an increased risk stratification, they have poor predictive value and therefore have not are not sort of tests that are required to start TPT in high incidence settings for persons living with HIV. Now, there are some new tests, such as the QuantiFERON Plus. It's a similar test to the older generation IGRAs. It just has some additional TB-specific antigens and involves 4 tubes as opposed to 3 tubes, so a little bit more blood collection. It still requires a specialized lab. The manufacturer is looking to do more field-friendly testing modalities. There are also new skin tests such as CTB, which use the ESAT6 CFP10 antigens that are in the QuantiFERON assays. However, these novel tests are not routinely available just yet, so they're not yet recommended by the guidelines. And then there's several other correlates of risk that have been studied or are being studied, and these include host gene signatures, measuring inflammatory profiles, and correlating that with clinical factors to try to develop risk prediction tools. But again, none of those are yet recommended for prime time. And I just very briefly draw your attention to this recent review, given that you may have heard of a lot of the excitement or heard about studies looking at how whole blood transcriptional signatures could be used to determine who's at risk of developing tuberculosis. And this recent systematic review and patient-level pooled analysis looked at 17 of the published signatures, which were RNA signatures between 1 and 51 gene transcripts in length. And they really found that these reflected, at best, short-term risk of incipient TB, and none of them met the WHO target test profile for prediction of TB in a 2-year period. And so these are not yet used for prime time. And there was a recent trial called the Cordis trial, which was presented using the host gene signature and targeted TPT strategy. And there they showed that there may be some role for it, but I would say that it needs a little bit more assessment before it's has clear guidance on how to use these signatures for clinical management. So the current algorithm that the WHO proposes is shown here. If you're HIV positive, and if you have any symptom of either cough, fever, weight loss, or night sweats, you need to get investigated for TB. If you're ruled out or don't have any of these symptoms, then you ask about if preventive therapy is contraindicated, such as having had a severe allergy, or they're on a medication that has clear indication for a severe drug-drug interaction. If that's not the case, then you can go ahead and initiate your TB preventive therapy. So a very simple algorithm. And I think that there's now absolutely no question that giving a combination of TB preventive therapy along with antiretroviral therapy is actually better than either one alone. This was a recently published systematic review looking at 3 trials that studied the risk-benefit of antiretroviral therapy with INH preventive therapy. And it found that the combination was better than either one alone to reduce both TB incidence as well as mortality in persons living with HIV. And specifically, there was 32% more reduction in TB with the combination. So definitely, if you have patients doing well on ART, there is added benefit to using the TPT. Now, mind you, these studies are all from very high incidence settings of South Africa, Malawi, and Cote d'Ivoire. So we know that in lower incidence settings, obviously, there may be a different actual absolute risk reduction, but regardless, the WHO and the rest of these high incidence setting guidelines do recommend the combination. So in terms of prior to treatment, I think you all know this. You want to assess for medical conditions, ask about liver disease, neuropathy, test for pregnancy, and what medications are on, ask if they've ever been treated for LTBI or TB disease, and establish rapport with the patient and explain therapy and adverse effects. One question that sometimes comes up is who should get baseline liver enzyme testing. This depends on your various individual practice and guidelines, but these are some of the broad recommendations. If they have known underlying liver disease, if they're pregnant or recently have delivered, if they consume alcohol regularly, or they're on other medications that could cause hepatotoxicity. Those are guidelines for testing for LFTs. Now, what are the regimens to consider? So basically, the premise of TB preventive therapy lies on the power of 2 classes of drugs, isoniazid and the rifamycins. And for the longest time, we've sort of relied on isoniazid monotherapy, either for 6 months or 9 months, and there are even studies showing lifelong, but those have sort of not gained a lot of favor in the guidelines. And then there's using rifampin, which is a cheap and readily available TB drug. And there's data to support 4 months of rifampin daily. There's a combination of INH and rifampin given daily for 3 months, known as 3HR. And then more recently, there's a lot more interest in these combinations of INH and a longer acting rifamycin known as rifapentine. And this can be dosed either weekly, given for 3 months, or daily given for 1 month, and I'll briefly go over those. So there have been now several trials looking at this regimen known as 3HP, which is the weekly INH rifapentine given for 12 doses, and it's essentially shown to be non-inferior, almost superior to INH in adults, adolescents, and children. It's safer, and it has better adherence and treatment completion. And these are just the data showing the difference between 9 months of INH and the 3HP regimen, showing reduced TB incidence in both HIV uninfected and infected. And then more recently, there was a large trial involving 3,000 HIV-infected persons, a global trial from many high-burden countries, where most with CD4 470, most of these individuals, if they were on ART, were in an efavirenz-containing regimen, and this was a 1-month daily isoniazid rifapentine regimen. So imagine this was compared to 9 months of isoniazid. So a short, ultra short course of 1 HP, as it's known, showed that it was more readily completed, had fewer side effects, and had the same reduction in TB incidence as did 9 months of INH. And that's shown more clearly here, irrespective of whether you had a positive IGRA or TST, or if you were on ART or not. And that's just, again, shown figuratively here. It was completely non-inferior to 9 months of isoniazid. The other trial I wanted you to just be aware of that was published in 2018 was this 4 months of rifampin. And this compared to 9 months of INH, showed excellent safety with the 4 months of rifampin, both for adults and children. The main caveat here is that there was a relatively small number of HIV-infected persons, but nevertheless, this is another option, particularly in places where rifapentine may not be readily available. And if you have ART that can manage to be co-administered with rifampin, which we'll talk about in a few minutes. So these here are the guidelines for the different regimens that exist for treating latent TB infection for HIV-infected persons. So I showed the CDC guidelines, the DHHS guidelines, which are ART guidelines, the OI guidelines, and then the WHO guidelines. The green boxes showed the preferred regimens, with the regimens on labeled in the top, and the yellow are sort of alternatives, and the magenta sort of / red color is the no evidence is either available or there's no specific recommendation made. And so here we have for 3HP is the preferred regimen for all the guidelines except for the DHHSI guidelines. And you can really only use this for raltegravir or efavirenz-based regimens based on the OI guidelines there. You can see that the 4R is an alternative regimen for the WHO guideline. The 3 months of rifampin INH is a preferred regimen, as is the 9 months of INH, as is the 6 months of INH. And the 1 HP has just recently made the guideline, and for now is an alternative regimen. And part of that has to do with the fact that we have not studied the impact of daily rifapentine and many of the antiretroviral regimens that are commonly in use. And I'll go over those in just a few minutes. So in terms of selecting a LTBI regimen for persons living with HIV, well, you want to sort of choose based on adherence, drug-drug interactions, the potential for side effects, and preferences. You also want to take a look at certain side effects such as flu-like hypersensitivity with 3HP. Clearly, drug interactions are a big issue. The longer the regimen, you have to worry about adherence issues. And for INH, you have to think about alcohol and the risk of hepatotoxicity. And then I think for, when you're going through counseling patients, you want to show them what are the potential number of pill burden and number of doses they'd have to take. So obviously, the longer the INH regimen, the more pills and the more doses over the lifelong. Whereas with the 3HP, that's 12 total treatment doses. So that's the shortest regimen. And then, of course, 1 HP is 30 doses because it's daily. Here just is showing you a schema for the type of pill. There is now a new co-formulated isoniazid rifapentine pill, which can be done. And so if you're on 3HP, once a week, you take 3 pills along with vitamin B6. And if you're on the 1 HP, you would have to take 1 of the co-formulated and have to have the 2 rifapentine given separately. Based on weight-based dosing, and then, of course, your vitamin B6. So you would want to explain that and counsel patients accordingly. I'll now switch to drug-drug interactions, which I think is really critical to when we're thinking of selecting a regimen. Here I show the ARV class, and you can see that isoniazid is sort of really has the least number of drug interactions with ARVs. The only exception is in that a subset of slow metabolizers of efavirenz and slow metabolizers of isoniazid, you can have increased levels and risk of higher drug concentrations of efavirenz. Otherwise, right now, what we know, Biktarvy has significant drug-drug interactions with rifamycins, both rifampin and rifapentine, and should not be used. With dolutegravir, you have to double the dose of dolutegravir, so with rifampin. And with 3-HP, the Dolphin trial published by Dooley et al. Shows that you can use dolutegravir with 3-HP safely. It has not yet made the most recent guidelines, but that is expected. However, with regimens that are combination dolutegravir rilpivirine, you should not use the rifamycins. For ralotegravir, you have to double the dose with the rifamycins, and you cannot use elvitegravir or cobicisstatin or TAF for that matter with the rifamycin. So this is important given the rollout of integrase inhibitors. With respect to efavirenz, you can, that is the one class of drugs that can be used safely with the rifamycins. However, the other NNRTIs such as etravirine, nevirapine, and rilpivirine cannot be used with rifampin or rifapentine. And similarly, the protease inhibitors cannot be used due to the significant drug-drug interaction. And then lastly, we don't use maraviroc much, but you need to use a higher dose of maraviroc with the rifampin. And I show these slides here. You can review them on your own time. I'm not going to go through them in detail. I just have all the details of the regimens and the interactions for your reference, and you can look these up. This is just a reminder that it's not only the antiretroviral therapy you need to worry about. Please do remember to look up the other medications patients may be on, because there are other interactions of importance that also have to be considered. And another piece, obviously, is the counseling and monitoring and adherence. Many of your programs and our programs have self-monitoring, and that's, these are otherwise healthy people who are not having signs or symptoms, and therefore they're taking a medication for prophylaxis. You want to be able to give them warning signs of what to look for should any of them develop hepatitis, including the anorexia, dark Rearin, rash, fatigue, fever, and to stop taking medication should any of these symptoms develop, and to seek prompt medical evaluation. With the 3-HP, there's occasional reports of flu-like illness, hypersensitivity reactions, so to counsel patients about that. And of course, if anyone has abnormal LFTs and you feel you need to implement them or they develop them, you have to continue to monitor their LFTs and certainly maximize adherence using strategies such as video DOT or phone call or pill box reminders. There's no test of cure, but adherence prevents up to 90% of subsequent disease. So I'll briefly end on talking about a few special situations, what to do about multi-drug resistant TB. I mentioned that for quite some time, WHO had a watch and wait policy. Now there's some recommendation based on a limited cohort study data with very few HIV infected persons. The WHO recommends doing the LTBI testing for people who've been exposed to multi-drug resistant TB, and recommends regimens that either include fluoroquinolones alone, fluoroquinolone with ethambutol, or fluoroquinolone with ethionamide plus or minus isoniazid if a 3-drug regimen is warranted. They've also been reports of using drugs according to the DST, the drug susceptibility of the source index case. On this slide, I won't go through all of it. It just shows the various small studies that have looked at the types of regimens offered to people who've been exposed to multi-drug resistant TB. And you can see most of these have included a fluoroquinolone and either alone or in combination. There are currently now 3 trials underway to really study this question, and some of them are including HIV-infected persons, the TB CHAMP and the Phoenix trials. We will have hopefully some information about how to manage an HIV-infected person who's been exposed to multi-drug resistant TB with more robust data. What about if your patient's pregnant or breastfeeding? For most latent TB therapy, it certainly is a question of whether the participant wants to initiate it during pregnancy or delay it until after delivery. When they're HIV infected and not yet on ART, the guidance from the WHO is to recommend initiating it. However, I will say it's important to think about knowing some of the literature and to counsel your pregnant women. We recently completed a trial and found that HIV infected pregnant women who started their INH in pregnancy compared to deferring it till after delivery had an increase in some composite adverse pregnancy outcomes. However, there's also some data showing that this risk is mitigated by the benefit of preventing TB. So the WHO is still recommending IPT initiation in pregnancy for the time being. We'll also say that the 3HP regimen appears to be safe based on a small study of 50 women, half of whom were HIV infected. And so the 3HP regimen can be used for pregnant women who are on an efavirenz-containing regimen, but not really known if they can be used. It's not been tested for any of the other ARV regimens. Isoniazid is safe for breastfeeding given with pyridoxine, and it's likely that 3HP and 4R are also safe, but there's little data. And one of the issues is to keep in mind that while there are slow concentrations in breast milk, if someone is on a rifamycin and an infant's on nevirapine, you want to think about some potential small risk, theoretical risk with interaction and reducing the nevirapine efficacy in breastfed babies. I'll end on saying a few things about recent data. There was a trial to look at whether giving repeat courses of latent TB treatment for those residing in very high incidence settings, such as South Africa and Ethiopia and Mozambique, where they gave a course of 3HP every year, comparing it to just giving it once and done, if you will. And these were results presented at CROI 2020 of the WIT3 TB trial. And importantly, giving the annual course did not provide any additional benefit than giving to people who just needed one course for people on ART. So basically no benefit of doing additional repeat courses. Once is enough when you're on ART to get the benefit of LTBI therapy. There's a whole bunch of tools to promote adherence, and you can pick and choose if you have these at your access. You can use smartphones, you can use pill boxes, you can use urine dipsticks to check to see if INH is actually being taken. This here is shown the isoscreen assay, MERMS, and EMOCA smartphone approaches. And I think what's exciting is that there still is a lot of future for looking at new interventions for a latent TB therapy and prevention. So these include getting shorter and shorter regimens, as well as the advent of TB vaccines. So I'll end by saying that we'll probably be testing some new combinations that include things like bedaquiline with or without other agents, which are shown here, which can very rapidly reduce the TB in the mouse model. And you have here also, like with ART long-acting drug formulations, interest in developing long-acting bedaquiline or other TB drug regimens with nano formulations, but it's still early days. And then, of course, there's really some exciting news for TB vaccines with these new subunit vaccines or recombinant BCG vaccination or ID93. And so we really do need to see how these products fare for HIV-infected persons. But this is exciting days and going beyond the standard BCG at birth strategy for preventing TB. So in summary, I want to let you know that TB preventive therapy works and is necessary to end the TB epidemic. Uptake of TPT needs to be improved and is of additional value beyond just giving antiretroviral therapy. LTBI testing is helpful but not required. There are several newer short course regimens that have the potential to greatly increase the use of preventive therapy in high-risk populations such as those living with HIV. The 3-HP regimen is easy, safe, and effective and can be used with efavirenz, raltegravir, or dolutegravir. The new ultra short course 1-HP regimen is also easier, safe, and effective. It can be used with efavirenz, but we need to know how it will work with these other integrase inhibitor regimens. We don't have data for that yet. Using short course rifampin regimens, you need to double dose integrase inhibitors such as dolutegravir. And then we'll be hopeful for the future that they're going to be that they'll be long-acting injectable once and done type of regimens, as well as TB vaccines for the future. So I'd like to thank all the organizers and appreciate your time and attention.